Okay, I think this seems like a good time to get started. Thank you, everyone, for being here today. And if people see my mouth moving and don't hear anything, feel free to put comments in the chat, or if you notice any other technical glitches that are important for us to know. So I'm going to begin with some orienting information and an introduction, and then we'll get into the talk followed by the Q&A. To begin with, I would like to acknowledge that UBC's Vancouver Point Grey campus is situated on the traditional, ancestral, unceded territory of the Musqueam people. And I would like to also acknowledge that you are joining us today from many places near and far, and acknowledge the traditional owners and caretakers of those lands. The nuts and bolts of what will be happening today are that we will have the talk till very approximately 1:30. Followed by a question and answer session from 1:30 to 2. For those of you who have questions come up during the talk, there is a Q&A bubble type option at the bottom middle of the screen. And so you want to use the Q&A bubble to put any questions that you want addressed. And people can also upvote questions in that Q&A bubble that they want answered, which will help prioritize questions for the end. Please note that this is not the chat function, so the chat function is different. The Q&A bubble is what you want for this particular purpose. Also, during the Q&A part, you will be able to use the raise hand function if you want to speak. And so the Q&A session will be a mix of me presenting moderated questions from that Q&A bubble, but also other folks will have the opportunity to speak and ask questions. And that brings us to our speaker for today. It is my absolute pleasure to introduce Dr. Ted Beauchaine, who unfortunately told me about 10 minutes ago that many people refer to his talks as TED Talks in the introduction, and how could I resist making the same comment that everybody else does once I heard that. Dr. Beauchaine is a professor of psychology in the clinical psychology area at Ohio State University. He earned his PhD in clinical psychology with a quantitative minor from Stony Brook University, which is a powerhouse clinical psychology program in the United States, and also where I happened to spend a few years for my first job. Dr. Beauchaine's work addresses the neural underpinnings of and the development of behavioral impulsivity, emotion dysregulation, and intentional self-injury across the lifespan, children, adolescents, and adults. One thing I really appreciate about his work is that while much of his work will focus on particular clinical problems like self-injury, he's also very much steeped in broad-based perspectives and frameworks, and has authored some highly cited bird's eye view papers on the intersection of developmental psychology and psychophysiology and other kinds of big picture topics. Also, every time I get to speak with him, like I did this morning, I always get so much out of the conversation because of that. Consistent with this sort of broad-based perspective, he is on the editorial boards of journals from diverse subfields. So he's associate editor of the journal Developmental and Psychopathology. He is also associate editor of the journal Psychophysiology, as an example. He also has worked with NIMH, the National Institute of Mental Health in the United States, on their research domain criteria, the RDoC, which has been influential over the past decade in the field. He is certainly well published. I could say that he has 20 publications, which will sound like a small amount for someone like him, but that's in 2020, which is not over yet. So obviously he's got his publications in the hundreds. His work is supported by funding from NIMH, National Institute on Drug Abuse, National Institute of Child Health and Human Development, several more. He has received awards in the past from the American Psychological Association, both for early career contributions and mid-career contributions, and the senior career contributions are around the corner. That's not a comment to say that you're getting old, though, just to be clear. And so without further ado, it is my great pleasure to introduce Dr. Beauchaine, and I know we are all giving him a warm virtual welcome. So I will now turn it over to you.
Thank you, David. I rest assured you can hear me?
We can hear you, and so far we can see you despite some of the technical glitches we struggled through in the beginning. So I think you're good to go, and hopefully they'll let us know in the chat if not.
Okay, it's strange not to see a bunch of faces, although I can see that there are quite a few people here, and thanks for attending. Thank you, David, for the invitation. I was so disappointed when I had to cancel last year because of COVID, and I'm so disappointed that I can't be visiting Vancouver, one of my favorite North American cities. The food's a lot better there than it is here, but it's raining and cold here today, so I feel like I'm there, and welcome everyone into my home. So these are strange times. And so I guess I'll launch right in. And my title might make it seem like I'm going to talk about suicide in adult males and pre-adolescent girls, and I will. It's going to be weighted heavily toward pre-adolescent girls. And after my conversation with David this morning, I would make some changes to this talk based on some of the broad conceptual ideas that we were chatting about. And I always like talking with David because I come away from the conversations jazzed and enthusiastic, and today's no exception. But hopefully some of those ideas will come up in the Q&A. So we do have some technical glitches, so I have to back off a little bit here so I can see my screen. We couldn't get the presentation on the proper screen, so yeah, let me launch in, and I'll also say that I'm going to make some assumptions about what most folks probably know who are in attendance because David is there, and so there are some basics that folks are probably aware of that I don't have to explain like I do for some other audiences. But if there's a way to ask questions as we go, I'm happy to address those. And so let me start with a little bit of background, and I'm going to walk through several of the research studies that we've conducted over the years. This is an entirely new talk, and it got me to reflect on some how things have progressed over the years in research on non-suicidal self-injury, suicidal behavior, and suicide, and how much has changed in a relatively short period of time, 15 years. First of all, suicide rates in North America, US and Canada inclusive, have always been highest among young First Nation and Native American men. That has been true ever since I've been in the field. And that is not a demographic who I will be addressing today. It's a very important demographic. And suicide rates in our Native populations are a tragedy, both here and in Canada, that require intervention. In the US as well, older white men suicide at higher rates than any other demographic group. And so if we look at suicide rates from age 15 or so all the way up to the mid-80s, what we see is that white men commit suicide, or suicide, excuse me, it's an anachronistic term, suicide at much higher rates than any other group. This is different in the US and Canada. So between ages, this high rate of suicide is common to Canada and the United States, but this massive increase in old age is a uniquely American phenomenon. And I just thought I would acknowledge that given the international audience. There's something about us down here in the States that leads older white men to suicide at a disproportionate rate. And I have my hunches about what that is, but that's not, and be happy to talk about that later, but it's not part of my talk formally. US suicide rates have risen in the past 20 years in all age groups. What we're seeing though is an especially troubling increase among women. So women are reaching parity with men in the worst possible outcome, suicide. Women's suicide rates are also increasing in Canada, so this is common to both of our countries. These are suicide rates from 1999 through 2018, and the first bit here is 1999 through 2012. among women, and what we see is increases in every age group except those who are older than 75. And the reason I draw this line is because that is when the American Foundation of Suicide Prevention and the National Institute of Mental Health laid out their zero suicide campaign. And so one would hope that that would translate into reduced rates of suicide, but in fact it hasn't. And so the increases in suicide among women have increased unabated since then. If we look at percent change among 45 to 64 4-year-old women, we've seen a 63% increase since 1999, a 44% increase among 25 to 44-year-olds, 51% among 65 to 74-year-olds, 93% among 15 to 24-year-olds, and the largest percentage increase has been among 10 to 14-year-old girls, whose suicide rates have increased 400% in that time frame. And even though these are lower rates of suicide than in other age groups, this portends increasing suicide rates in the future as survivors, if you will, in this age group mature. So these are troubling statistics. So 2 questions for my research group are currently, and haven't always been, but are currently, how do we identify vulnerable girls and men, which I should parenthesize here because that's not the data I just presented, before suicide attempts. And for girls, identifying self-injury before that occurs because it often portends later suicide. How do we identify those who are vulnerable before the onset of these behaviors? And second, how do we intervene to prevent progression of these behaviors? The traditional view, as David and I were talking about, is that suicide is impossible to predict accurately given its low base rate, and that's inarguably true. Even in high-risk groups. And so that's illustrated in this graphic here. If we look at suicide risk in common psychiatric disorders and cancer is at the bottom here, and it's interesting in the cancer literature, it's a big deal that the relative risk is 1.8 times higher among those with cancer than among those in the general population. However, if we look at those who have a prior suicide attempt, the relative risk is 38.4, which means those who have attempted suicide in the past are 38.4 times more likely to engage in a suicide attempt than the general population. And if we move down the line here, we've got increased relative risk in this order for major psychiatric disorders. However, if we look at incidence, percent in the past year, or in the current year, who will attempt, it's only 1 in 182 people who have a prior attempt. It's only 1 in 342 people who are diagnosed with major depression, 1 in 364 for mixed drug abuse, and then on down to cancer, 1 in 3,846. So this illustrates the difficulty of predicting suicide. So even among the highest risk people, our ability to predict over the course of the next year is very low. And so how do we resolve the low base rate problem? And can we resolve the low base rate problem? And there are 2 general approaches for prevention. And one is secondary prevention. And that focuses almost exclusively on imminent risk for suicide. Is someone going to engage in an attempt in the very short upcoming interval? So that's the current NIMH, National Institute of Mental Health, priority here in the United States. And so there's a ton of money being poured into ecological momentary assessment techniques, scanning social networks like Facebook and Instagram for clues that someone might be at imminent risk for suicide. The goal is to identify markers of risk in the minutes, hours, or at most days before ideation and attempts. And so if we look at the thinking, the philosophy behind that, the lifespan of a person, and I'm a developmental psychopathologist, so I'm interested in how psychopathology emerges across the lifespan. From birth to suicide event, we're trying to identify imminent risk behavior right before the event so that we can somehow intervene. And as David and I were talking about earlier this morning, that's kind of like asking what happened in the minutes, hours, few days before the heart attack, and expecting to be able to prevent heart attacks from examining imminent risk for heart attacks. So that is not the approach that we prefer, even though there's a lot of money being spent on it right now. We prefer a primary prevention approach, and that is where we focus on identifying complex combinations of risk. And so we acknowledge and model interactive effects of biological and environmental risk factors across development with the goal of preventing future self-injury and suicide attempts by altering mechanisms months and years before imminent risk emerges. And so that approach can be characterized more like this. So between birth and a suicide event, there's a lot going on. First of all, we are all born with certain biological vulnerabilities or sensitivities. One of those that's important for suicide risk is impulsivity, which is characterized as temperamental features like ADHD. That alone has very poor predictive power, as you might imagine. There are plenty of people with ADHD who never think about and never attempt suicide. There are environmental risk exposures like sexual abuse and maltreatment. That alone has poor positive predictive power as well, or those alone have poor positive predictive power. But when they get combined, when we have, as I'm getting a little ahead of myself, but when we have temperamental impulsivity and someone incurs sexual abuse or maltreatment, risk of self-injury and suicide increases dramatically over and above either alone. There are social influences that are important, deviant peer group affiliations and drug use. Self-injury in particular shows strong social contagion in certain peer networks. And then, of course, we have early signs like self-injury, which portends risk for suicide attempts. And then adverse events, and this is consistent with David's model, where we've got a capacity, if you will, and then that can be triggered by painful experiences, including adverse events that include loss and rejection. And so there's a lot that goes on. There's a lot, if you will, that precedes a suicide event. And can we identify risk enough to enroll people in prevention programs? And so all of these represent opportunities for prevention. So our developmental theory of non-suicidal self-injury and suicide risk is really about 10 years old, and it's based on a number of observations that I'll summarize very quickly. And one of those observations is that among adult women in particular, and most of what I'm going to be talking about for the next while is the development of self-injury and suicidal behavior among women, not men, that self-injury oftentimes precedes suicide attempts and suicidal behaviors. Not always, but oftentimes. And so that's an important thing to note. Suicide attempts are most likely, according to our developmental theory, when highly heritable trait impulsivity, which is expressed early in life as symptoms of ADHD, both in preschool and middle school, when that interacts with or is combined with environmental adversities like maltreatment, physical abuse, and sexual abuse that promote emotion dysregulation or the inability to dampen strong negative affect. And that would be a talk in and of itself. How do these environmental adversities promote emotion dysregulation? I'm asking you to take that statement on faith for the time being. So our research goals are to specify biological markers and environmental risk factors so we can identify and target vulnerable girls as early as possible, and then again develop and test preventive interventions for them. And it's important to state that there are currently no preventive interventions for vulnerable preadolescent girls despite that 400% increase in suicide rates over the last 20 years. Not only have we seen an increase in suicide rates, but the age of initiation has gone down over the past 15 years as well. So we're seeing more girls initiate self-injury and suicidal behavior preteen than we did a decade ago, and they incur more hospital visits. They engage in more lethal self-injury and suicidal behaviors. And so the earlier the age of onset, as in many forms of psychopathology, the more severe typically the behaviors. And so we first published our developmental theory in 2009 in a paper in Psychological Bulletin. Then I had the pleasure of co-authoring with Marshall Linehan and Sheila Cole. Sheila is now a professor at University of Utah, who was a graduate student at the time. And early in my career, it was a fabulous opportunity to be on faculty at University of Washington with Marshall Linehan, who taught me a lot. We had a grant on opiate-dependent women with borderline personality disorder, who of course engaged in high rates of suicidal behaviors. And Marshall was very much ahead of her time in that way. No one else was studying opiate dependence and suicidal behavior among women with borderline personality disorder. That would not be uncommon now. I feel most sorry for Sheila, who had to try to thread a needle between Marcia's feedback and mine on writing this paper, and she did it with aplomb. But there were a lot of conjectures in this paper because data weren't in yet about our theory of impulsivity and emotion dysregulation combining to increase risk for borderline personality disorder development, including non-suicidal self-injury and suicidal behaviors. We published another paper that year that was more detailed in terms of neurobiology, but was the same theory. And we just published what I would consider to be a 10-year update. And this is a paper that appeared last year in Clinical Psychological Science. And in this paper, we review all the data that have come in the intervening 10 years. And both by our research group and others. And for the rest of this talk, I'm going to concentrate mostly on our work because I have the opportunity to do that. But there's a lot of work that's been going on development of self-injury and suicidal behavior in girls. So let me quickly talk about trait impulsivity as a behavioral construct. And most of you are undoubtedly familiar with this. But trait impulsivity is an individual difference. And when it's extreme, it's expressed as a preference for immediate rewards over delayed rewards, actions taken without forethought, failures to plan ahead, deficiencies in self-control. That looks an awful lot like a list of symptoms, or a partial list of symptoms for ADHD. And of course it is. As an individual difference, trait impulsivity is a normally distributed personality trait. It's not as if someone has it or doesn't have it. It's some arbitrary cut point where we decide if someone has ADHD or not. And so if you look at the highly impulsive end of the continuum, we've got ADHD. And then at the other tail, we've got restrained behavior, and then everything in between, from unimpulsive to exuberant, and again to ADHD. Impulsivity, trait impulsivity is highly heritable. It doesn't matter whether you're measuring the personality trait or ADHD itself, since in essence they are the same thing. Heritability coefficients are about 0.8. As early in life as you can measure impulsivity. It's stable across development. And I won't talk much about this today, but a lot of our research addresses how impulsivity is rooted in brain processes that can become canalized across development in contexts of environmental risk. So let me quickly show you some of the characteristics of our self-injuring samples. And I've taken this table from our very first sample of self-injuring adolescent girls who were ages 13 to age 18. And there were 23 in each group. And this shows the number of self-harm events with intent to die, ambivalent, without intent to die, and requiring medical attention in this group. And we recruited these adolescent girls based only on self-injury. And so we didn't care about ADHD, we didn't care about depression, we didn't care about bipolar tendencies. We only recruited based on self-injury. And the inclusion criteria were 3 or more self-injury events of moderate lethality in the past year or 5 or more lifetime. And what you can see with only those inclusion criteria is that we got a lot of self-harm. And so the mean number of self-harm events lifetime reported was 156.8. Now, I don't give that any credence in terms of accuracy, but it is telling us that they're engaging in a lot of self-injurious behavior, and a lot with intent to die. If you look at parent reports, parents are in agreement that there's a lot of self-harm going on. They don't know how much. Even parents are reporting intent to die in about half of the sample. So these are fairly high levels of severity. If we look at psychopathology in this same sample, we can see that based on child behavior checklist reports, these are parents, we have parents' self and teacher reports, which are largely in agreement. We see that attention problems are high, as we would expect given a self-injury sample based on the narrative or rationale that I was giving you. So across the board, we see high levels of psychopathology. And so you can see what the problem might be is if we want to explore self-injury and suicidal behavior, specifically among depressed adolescent girls. That would filter in a way that I'm not sure what we would obtain, but if we recruit based solely on self-injury, we get high levels of psychopathology across the board. And so we're talking about T-scores here for attention that places these girls 2 standard deviations above national norms on attention problems. And the CBCL combines hyperactivity, impulsivity, and inattention all on the same scale. And so that's a little bit of background. And so the way that we view development of self-injury, at least for some girls, and suicidal behavior and suicide attempts, is that we've got temperamental impulsivity again combined with emotion dysregulation. Temperamental impulsivity is highly heritable. Emotion dysregulation is largely socialized, and that's another broad literature that would be a talk all on its own. And so over time, how do these temperamental predispositions and socialized deficiencies in emotion regulation interact and magnify one another? And so this is a transactional perspective. Now, what I'm going to do now is go through some of our individual studies that we've conducted over the years. I'm not suggesting any ordering in terms of lifespan, but I'm breaking them into temperamental and self-regulatory components, even though that's even an artificial distinction, as you'll see. And so our very first study that we conducted was on autonomic vulnerability to self-harm. This is that sample that I just described to you. The paper was first authored by Sheila Kroll in 2005. And to give you an idea of how much things have changed in the last 15 years, we were referring to non-suicidal self-injury as parasuicide at that time. And now we consider that term to be anachronistic, and I don't know what else we consider it to be, but don't use that term or you won't be taken seriously. Whereas back then, that was the term we used. And so this graph shows parasympathetic nervous system responding assessed via respiratory sinus arrhythmia across 6 epochs of a sad mood induction. And so these adolescent girls were watching a film of a young boy with his dying father. And this was hard to get through our IRB at the time. There was people were circumspect about studying non-suicidal self-injury There were worries about, well, what if you get them in the lab and you precipitate an event? Thankfully, the field has come to a place where now we study these populations on a regular basis. But back then it was very difficult to get this through IRB. And we eventually did. And what we found in this study was a difference between control adolescent girls and those who engage in self-harm, both at rest, so they had lower resting respiratory sinus arrhythmia. And then as this film unfolded and things got more emotionally evocative, their respiratory sinus arrhythmia went down, whereas in controls, it went slightly up. And so we're seeing both, again, a baseline and a reactivity difference between these groups. And in the intervening time, it's become clear that respiratory sinus arrhythmia is a reasonable biomarker of self-regulatory capabilities. That study, in some sense, let us know, first of all, that emotional regulation does appear to be an issue, both in terms of self-report and neurobiological markers. It also let us know that we wanted to continue doing this work and learn more. The next study with the same sample is one where we evaluated genetic vulnerability. I'm using a fairly crude index of genetic vulnerability, and that is platelet serotonin levels. And what we found in this study is that, first of all, we had mothers and daughters engage in a conflict discussion. And so this is a fairly typical thing to do, where we had them come into the lab and list 5 things that they argued about most. So independently, mom listed those 5 things, daughter listed those 5 things, and then we as researchers looked at those 2 lists and decided to pick something for them to argue about that wasn't likely to end the world, but that was likely to elicit reasonable conflict. And this works fabulously for essentially all adolescents and their parents. Works much better for girls than for boys who can sometimes sit there and say nothing. But it works for control adolescents as well as those who self-harm. And so it's not hard to get moms and their daughters to engage in these conflict discussions. What we found is that the relationship between negativity in these mother-daughter interactions and self-harm was conditioned on serotonergic risk. So these are, again, platelet serotonin levels. And what we found is that those who were below the median on platelet serotonin tended to engage in self-harm regardless of level of mother-daughter negativity and conflict, whereas those who were above the median on platelet serotonin, there was a strong correspondence between dyadic negativity and self-harm events. And I should say that serotonin levels have been implicated in impulsive behavior in a fairly substantial literature. So that was our initial sample and our initial foray, if you will, into studying suicide risk or self-injury among adolescent girls. The next study I'd like to describe is one where we evaluated neurohormonal vulnerability in self-injuring and depressed adolescent girls. This is a different sample where we have 28 adolescent girls, again, 13 to 18 years old, who were self-report diagnosable levels of depression versus those who self-report self-injury and diagnosable levels of depression. And we had them undergo a dexamethasone challenge. And many of you are probably familiar with this, but in case you're not, a dexamethasone challenge is a test in which you administer dexamethasone in the evening. And dexamethasone is a synthetic glucocorticoid. And that administration of dexamethasone should suppress cortisol production by the HPA axis. And so the next day you measure cortisol, and if someone has a normally functioning HPA axis, cortisol levels will be lower the next morning. And that's called dexamethasone suppression of cortisol. For many others, including several studies of suicide and suicide risk, we don't see that suppression of cortisol reactivity. And what we found here is less cortisol suppression for the self-injury and depressed adolescents. Importantly, this accounted for self-harm over and above effects of internalizing and externalizing psychopathology. So dexamethasone non-suppression was related to self-harm over and above general psychopathology. The next study that I'll describe was a study of central nervous system function in another sample of self-injuring adolescent girls. And this study followed from our hypothesis that, excuse me, impulsivity is a predisposing vulnerability to non-suicidal self-injury and suicidal behavior. There is a well-established literature, and there was at the time, of certain neural markers, if you will, of attention deficit hyperactivity disorder, especially the hyperactive impulsive and combined subtypes, particularly in terms of striatal under-responding to rewards. And the striatum, of course, is part of the mesolimbic reward system. And what we found in this study is reduced striatal, amygdalar, and orbital frontal cortex activation while anticipating rewards or incentives using Brian Knutson's monetary incentive delay task, which is so common in the literature. And the interesting thing about this sort of summary image is that if you knew the ADHD literature well, and I showed these figures to you, you would probably say, oh yeah, that looks like a pattern of reward responding in a group of boys with ADHD. And in fact, this figure is from Plickett and Scher's meta-analysis of studies of ADHD, and it shows hypoactivation in striatal regions in virtually all studies that have used monetary incentive delay tasks, except one. So the striatal regions are right here, and we see that pattern of underactivation in girls who were recruited solely on the basis of self-injury, not on the basis of impulsive behavior. Although self-injury, it turns out, is often an impulsive behavior. So using that same sample, we also evaluated central nervous system vulnerability. And this is a structural MRI study where we evaluated particular regions that have been implicated in adult borderline personality disorder. And so no studies had been conducted at the time evaluating neural structure, if you will, in girls in adolescent girls who engaged in self-injury. And so our comparison was the adult borderline personality disorder literature. And interestingly, when we recruit based on non-suicidal self-injury and self-harm, other forms of self-harm only, a plurality to about 2/3 of girls already meet criteria for borderline personality disorder, which we always assess, even though they're not 18 yet. And so the notion that you can't assess personality disorders prior to age 18 is not in fact true. And so we've got 21 self-injuring and 21 control adolescent girls. And the regions that we found differences in were the bilateral insula in the right inferior frontal gyrus. These were some of the regions of interest we examined, not all. And those brain regions are implicated in self and emotion regulatory functions. And the findings, in fact, parallel findings from adult women with borderline personality disorder and males with externalizing behavior disorders. An interesting aside on this is that these are some of the regions that are implicated in borderline personality disorder in adulthood, not all of them. And so that leaves questions open about, are further neuromaturational changes going to occur in these girls as they mature? Or perhaps the sample size was too small, or perhaps it's those who don't have borderline personality disorder who are contributing to fewer regions being significant than we initially predicted. The next study that I'll describe is one where we evaluated behavior dysregulation in mother-daughter conflict discussions. This is a different sample than the original sample that I described, where we recruited 24 depressed, 24 typical control, and 26 self-injuring adolescent girls, again, ages 13 to 18. And here they were engaged in a conflict discussion with their mother, exactly like the one I described. And we used multi-state convergent cross-mapping, which is a nonlinear dynamic method, to evaluate who was, quote unquote, driving behavior in dyads. That's a term from the multi-state convergence cross-mapping literature. So this is an attempt to get directional associations between mother's behavior and daughter's behavior and daughter's behavior and mother's behavior. And so the first graph here is angry, aversive mother behavior driving adolescent behavior. So we painstakingly coded mother's and daughter's behavior, and some of the behaviors that are included in this category are outward expressions of anger, derisiveness, contempt, those kinds of expressions. And what you see here is that for controls, angry, aversive mother behavior isn't causing their daughters to react in kind. This isn't about differences in group levels of aversive behavior. Those were very small because the task worked so well. If we look at depressed and self-injuring adolescent girls, they are much more reactive to their mother's behavior, both of them. If we look at angry, aversive adolescent behavior driving mother behavior, for none of the groups was there a lot of that going on. So mothers weren't reacting to their daughters in the same way that depressed and self-injuring daughters were reacting to their mothers. And these are roughly analogous to 95% confidence intervals. And so what you see is essentially no difference in mother's behavioral reactivity, but some big differences in daughter's behavioral reactivity. And so that's at the behavioral level of analysis. We also evaluated physiological reactivity in these groups. And so this is the same sample. I've already presented the behavioral findings. Those are grayed out here. If we move over to the middle column here, we've got angry, aversive mother behavior driving adolescent respiratory sinus arrhythmia. So we had adolescents and their moms both wearing electrodes to measure a bunch of different physiological reactivity indexes. And what we see up top here is, again, angry, aversive mother behavior driving adolescent respiratory sinus arrhythmia, or RSA withdrawal. And the self-injuring group here is different from the depressed and control groups. So self-injuring adolescents are physiologically more reactive to their mother's aversive behaviors than depressed or control adolescents. If we move down here to moms, we can see that control and self-injuring adolescent moms are equivalently reactive, if you will, and the depressed, the moms of depressed adolescent girls drop right off the map. And so that's an interesting observation, but not one that we were especially interested in. If we move over here to electrodermal reactivity, so here we had a parasympathetic measure with RSA. Now we've got a sympathetic measure with electrodermal reactivity. There's a similar story. So the self-injuring adolescent girls are more sympathetically reactive to their mother's aversive behaviors than control or depressed adolescents. no differences in terms of mothers being reactivity. So the bottom line here is that girls who engage in self-injury are, I don't know if I would go so far as to say exquisitely reactive to their mother's aversive behaviors, but they're certainly more reactive at the physiological level than their depressed only and typically developing counterparts. The next study I'll describe is one where we evaluated mediating mechanisms in a much larger sample. And this one isn't as directly related, but I think it's important anyway. I've got some crazy stuff going on here. So we've got 206 families in this study. And we evaluated maternal antisocial personality disorder and borderline personality disorder symptoms, and how those were related to later child externalizing problems. This is a well-known association, so there's nothing groundbreaking about that. We evaluated whether child emotion regulation difficulties mediated the association between maternal antisocial and borderline personality disorder symptoms and later child externalizing behaviors. These are just control variables in the upper right here. And we found support for that. It was a full mediational effect. And why is that important? It's important because of relationships between externalizing psychopathology and non-suicidal self-injury and suicide attempts as well. And so these data are from the Berkeley Gals with ADHD or B-Gals longitudinal study that my colleague and collaborator Steve Hinshaw initiated and Amore worked on as a graduate student. And so the traditional thinking about vulnerability to non-suicidal self-injury and suicidal behaviors up to, I don't know, maybe the past 7 or 8 years is that internalizing psychopathology, depression and anxiety are the greatest risk factors or vulnerabilities to non-suicidal self-injury and suicide attempts. However, if you take girls at ages 6 to 12, girls who are specifically impulsive as indexed by early life ADHD, evaluate their behavior or assess their behavior at ages 18 to 11, and then follow them up at ages 17 to 24, so there's some overlap here. Childhood ADHD is associated with adolescent non-suicidal self-injury and suicide attempts through externalizing psychopathology. The internalizing pathway drops out when you account for externalizing psychopathology. And it's also mediated through peer rejection and victimization. So these things turn out to be more important than internalizing psychopathology. But of course, as we saw earlier on, we see high rates of all of these things in self-injuring samples. And so family mechanisms, if you will, of externalizing psychopathology are important to understand when we're talking about development of self-injury and suicide attempts. And so then the last, not so much study, but summary of the data to date in the field that I want to talk about is the effect of abuse and maltreatment on emerging self-injury and suicidal behavior, specifically among girls who are impulsive. So these data come from a couple of sources. One is the Pittsburgh Youth Survey. Another is the Berkeley Girls with ADHD longitudinal study. Again, the BGAL study. That followed 140 girls ages 6 to 12 with ADHD. They were followed up in the late teens and early adulthood. And girls with ADHD who also incur physical and or sexual abuse are specifically those who engage in alarming rates of self-injury and suicide attempts. So this chart shows a population prevalence, first off, of self-injury. And alarmingly, close to 20% of adolescent girls are now engaging in self-injurious behavior. Many of them are what I might call dabblers, which is not unlike substance abuse. They engage in some self-injury and never go on to experience problems. but some percentage do go on to experience more severe problems. If we look at the rates of self-injury among maltreated girls, those rates increase to close to 30%. That's also true of girls with ADHD. If we look among girls who are diagnosed with ADHD and incur maltreatment, rates of self-injury jump up to 50%. And again, this is from a couple of different sources, one of them being the Beagle study. If we consider suicide attempts instead of self-injury, the population prevalence rate of suicide attempts, although increasing alarmingly, as I already talked about, is still fairly low. If we look in maltreated samples, the rate of suicide attempts is around 5 or 6%, slightly higher in samples of girls with ADHD. If we look among girls who have ADHD and incur maltreatment, rates of suicide attempts jump to 1 in 3. And so the combination of ADHD and maltreatment, abuse, those things that, that disrupt emotion regulatory processes among other human functions, when we combine that with impulsivity, we get these very high rates of both self-injury and suicide attempts, consistent with the theory that we laid out a decade beforehand. This collective body of work, combined with other things that have gone on in the literature and other contributions from many other research groups, has led us to this developmental or neurodevelopmental model of non-suicidal self-injury, borderline personality development, and suicidal behavior. And again, we're not saying that we're accounting for these behaviors across the board. We're talking about a subset of highly vulnerable girls who progress from ADHD to oppositional defiant disorder. At some point, they initiate self-harm. That worsens over time. Many of them engage in substance use and suicidal behaviors, and then eventually suicide attempts, and we have borderline personality development. And according to our formulation, trait impulsivity, that reward seeking, that highly heritable vulnerability that's rooted in neural systems of approach, this contributes to all of these behaviors across development. Whereas self and emotion dysregulation takes on an increasingly important role across development as it becomes more and more compromised. And this is subserved largely by prefrontal neural systems that are impacted heavily by socialization mechanisms, abuse, substance use, and the like. So now let me shift to adult functional outcomes of impulsivity and some of our more recent work. Few longitudinal studies have evaluated real-world functional outcomes among adolescents, among those who were diagnosed with ADHD in childhood, among adolescents or adults. We're starting to see some of these studies come out. Treatment studies, though, have focused primarily on syndromal outcomes. So if we treat ADHD with a stimulant, if we treat ADHD with empirically supported parenting interventions, do we reduce hyperactivity and oppositionality? Of course, that's a necessary precondition for improvement, but functional outcomes are arguably more important. In newer long-term follow-ups, several of them show minimal effects of evidence-based childhood treatment on adult functional outcomes. So speaking specifically about ADHD. So this is a paper from Steve Hinshaw and Jean Arnold. Jean is here at Ohio State, where they follow up the multimodal treatment of ADHD sample, which was almost 600 children with ADHD. Both the medication arm and the behavioral treatment arm reduced hyperactivity, impulsivity, oppositional behaviors immediately post-treatment. But long-term follow-ups of those middle schoolers who are now in their 20s, approaching 30, aren't showing positive results. And so that applies to educational attainment, income, high-risk sexual behavior, jail time, social skills, and the list goes on. these functional outcomes don't appear to be affected by early intervention. The study I'm about to describe is a study that we just published in Science Advances, where we evaluated associations between ADHD, financial distress, and suicide in the Swedish population. So the great thing about doing population-based work in Scandinavia is that as long as you have a Scandinavian co-investigator, you can access population-based data. And so the data I'm about to describe include ICD codes for over 11 million people, and that includes 176,350 people who were diagnosed with ADHD. And so you can do a lot with that kind of statistical power. Our objective, or we used objective credit data, and that includes credit requests, arrears, meaning unpaid bills, and credit scores from the Swedish Credit Bureau. And our objectives were to replicate and extend some of our previous work using self-report data, showing that financial distress and poor credit characterize adults with ADHD. Those aren't big surprises to anyone. We also wanted to evaluate associations between ADHD, financial outcomes, and suicide, controlling for assorted physical and mental health comorbidities. And so you can see why an enormous sample would be required to do these things. Associations between ADHD and financial difficulties are established. Associations between ADHD and suicide are established. But looking at the conjoint effects of ADHD and financial distress on suicide had not been evaluated to date. So this first graph shows credit requests per month by age in the Swedish population for those without ADHD and those with ADHD. One thing to note here is that these represent 95% confidence intervals, the gray, and it doesn't even look like there is a confidence interval for the no ADHD group because the sample is so enormous, the confidence interval is narrow. For those with ADHD, there's a broader confidence interval because the sample is smaller, but you can see that credit requests per month are higher among those with ADHD across virtually the entire age span assessed, and they diverge markedly at about age 30. So those with ADHD are asking for credit at much higher rates than those without ADHD. This next graph shows new consumer credit that was granted. And so there's a lot of requests for credit among those with ADHD, but they're being granted credit at lower rates than those without ADHD. So their requests are being denied. This next graph shows new arrears per month among those with ADHD and no ADHD. And what you can see is drastically increasing arrears, unpaid bills, unpaid commitments among those with ADHD up to about age 40. And then those start to taper off, but they don't come down to the non-ADHD population until around age 60. So one way to look at that is that's a lot of financial pressure. We don't know what the source of those, well, we know exactly where the arrears are, but we don't know what the source of financial distress is. If we look at the percentage with ADHD in different default risk bins, we can see that those with ADHD are much overrepresented in those at high risk of default. And this is essentially a Swedish credit score. I don't know how credit scores are computed in Canada, but in the United States, a higher credit score is good. In Sweden, a higher credit score is bad. So those with bad credit, ADHD participants are far overrepresented compared with the population-based rate of ADHD. If we look at prescriptions per capita, one thing to note here is that like in the United States, rates of prescriptions for ADHD increased dramatically from 2006-7 to 2014 and 15. So we've got 4 times as many prescriptions for ADHD in an 8-year period of time. This is still well below rates of prescriptions in the United States, but that's a pretty drastic change. Most of those prescriptions are being made when adolescents are 14, 15 years old, but we can see increasing rates of prescriptions at all ages, all the way on out to age 50. If we look at the association between prescriptions and new arrears or unpaid bills, we see none. So this shows when the prescription was initiated, which is time 0. If we go back to the 24 months before someone gets prescribed a medication for ADHD and the 24 months after, there's no association between prescriptions and financial behaviors. When we look at probability of suicide, we see higher rates of suicide among those with ADHD than among those without ADHD. The interesting thing here is that the suicide rate for those without ADHD drops below 0 with psychiatric comorbidities partialed out. If we look at the suicide rates during the observation period in different default risk bins, and here we collapsed the 11 default risk bins from the previous slide into 4 so we could get enough people with suicide to have stable estimates. What we see is that for those without ADHD, there's very little association between poor credit and suicide. For those with ADHD, there's a strong association. So the association between default risk and suicide among ADHD and suicide among those at low default risk is fairly small. If we move over here though, to those with ADHD who are at high default risk, suicide rates go up dramatically. And so there's a strong interaction effect here between default risk and ADHD in predicting suicide. So it's those with ADHD who are at especially high default risk who are also at especially high suicide risk. When breaking this down further, we evaluated financial behaviors in the 3 years before suicide for those with and without ADHD who suicided. For women, there was no association. So financial arrears, in this case, financial behaviors did not portend suicide. For men, the situation was much different. So for men with ADHD who suicided, their financial situations got increasingly worse in the first 3 years prior to suicide. So compared with those without ADHD who suicided. Now, we don't know what to make of this. We don't know if the financial stress was a triggering event for suicide. We don't know whether this reflects a more general pattern of chaos in the lives of those with ADHD who suicided. However, this could help us in identifying prospective risk for suicide among those with ADHD, regardless of mechanisms. And so a quick summary of financials and suicide among adult men. So combined ADHD and financial distress predict high rates of suicide over and above other mental health conditions and over and above physical health conditions that we also controlled for in the study. ADHD confers a 1 to 2-fold increased risk of suicide at normal default risk. This is nothing new. Many studies have shown this. However, ADHD confers a 5 to 6-fold increased risk of suicide at high default risk. And for men but women, arrears accumulate in the 3 years prior to suicide. These results are the first of their kind, and we hope that they help in identifying risk. And so adding financial data to psychiatric data may hold some promise for more specific earlier identification of suicide risk. Now, one thing to note, and this comes from my conversation earlier with David, this doesn't tell us when somebody is going to suicide. It doesn't tell us if someone's going to suicide. It helps us identify a group that's at much higher risk and then presumably we can formulate prevention programs. At least that's the goal. And so that's all I have. I went through that a bit quicker than I expected to. Maybe that's a byproduct of Zoom presentation. I want to acknowledge our funding sources. I especially want to acknowledge Steve Hinshaw and Sheila Kroll, who are integral collaborators on a bunch of this work. I never would have gotten into work on non-suicidal self-injury and suicidal behavior if not for Sheila, who was a graduate student who had such interest and convinced me that it was relevant to my work on impulsivity. And then the very broad array of people who have contributed to this work over the years. And this only represents the major contributors. There are many more. So I think that's it. And I would love to take questions at this point.
Well, thank you so much for that talk. I am new to moderating questions in this format, so as a reminder to people watching, in addition to the fact that we're silently applauding and you can't see that, and that is yet another feature of talks that we are robbed of by the pandemic. As a reminder to those who came in later, just want a reminder to ask questions. You can use the raise hand function, but you can also type in questions in the Q&A bubble. If worst comes to worst and you can't figure anything out, you can use the chat. I will moderate some of the questions. And by the way, you can also upvote questions in the Q&A bubble. So I'll do some moderation based on what pops up in the Q&A bubble. I will also try to keep an eye out for hands. And I also have a question of my own that I'm going to shove in there. So one question to kick things off is you alluded earlier in your talk to having hunches about why older American men have disproportionately higher suicide rates. I would appreciate hearing your hunches is one of our questions.
Okay. Is this coming from an American or a Canadian?
I think Canadian.
Okay, okay. Not that it matters, but it satisfies my curiosity. And I, of course, never have lived in Canada, although my grandparents immigrated from Canada. One of the, I think, there are probably more than one contributing factors. One of them very likely may be our healthcare system, where, my own father just died, and my grandfather suicided. And both of them were facing imminent health crises in old age that weren't taken care of appropriately because of lack of resources and a healthcare system that denies people with lack of resources access to adequate healthcare. I think that likely contributes. Another contributing factor is probably traditional sort of formulations of masculinity that we have in the United States, where men are supposed to provide, where men are supposed to be sources of resources for others. And when we get old, we have to rely and depend on other people, and that's not part of the American psyche. And so those are my two hunches. I'd love to hear others' hunches, and maybe we could round out the contributing factors, but that's my suspicion.
Great, thank you. And we're starting to get a bunch of questions coming in, so I'm going to have to actually step up and do some legit moderating. So I'll also try to peek if there's follow-up questions related to what you just said and prioritize those. All right, I think, okay. So another question, I'd be very interested to hear more about whether you think that the increasing prevalence of suicide risk for girls varies across culture, and if so, why? And I can always repeat a question if you want me to.
No, this is a fabulous question, and it's one that we've been thinking about and that we're pursuing. And so I have a collaboration with Ariel Sheftal at Nationwide Children's Hospital at the Suicide Prevention Research Center there, where we actually just got feedback on a grant proposal, some positive feedback. And one of our objectives in that grant proposal is to follow who we call parental history positive children. So these are children who have a parent who has attempted suicide. And so they're at much higher risk of suicide attempts themselves. And we are disentangling mechanisms and rates of suicide among those in our local Black community versus our local white community. And so we have hypotheses that the pathway that I've described applies much more to the Caucasian community in the United States, if there is even such a monolithic thing, than it does to some of our traditionally underrepresented populations in the US. We don't think the mechanisms are the same. We don't see the same rates of suicide attempts and non-suicidal self-injury among Black girls that we do among white girls. And I should also say that there's a reason that I didn't talk about boys, that boys are much more successful in whatever that means in terms of suicide events. They're much more likely to die from their suicide attempts, but they're also less predictable. There isn't a developmental pathway that I can lay out like we have for adolescent girls, even though their rates of suicide are higher. So yeah, that's a good question. I hope I answered it adequately.
Thank you. So some folks are not only putting questions in, but making use of the upvote function. And so we have a question that's been upvoted to the top, excuse me. The risk for non-suicidal self-injury and suicidal behavior related to maltreatment and having an ADHD diagnosis does not seem to be additive in adolescent girls. I would be interested to know your thoughts on the mechanism/interaction. I can repeat.
One more time, David, sorry.
Absolutely. The risk for NSSI and suicidal behavior related to maltreatment and having an ADHD diagnosis doesn't seem to be additive in the adolescent girls. I would be interested to know your thoughts on the mechanism or interaction.
Yeah. This gets at the core of our theory, so I totally appreciate this question. So our theory, as we laid it out originally in that 2009 Psychological Bulletin paper, and that I still believe, and again, this is more of a macro theory. It doesn't predict when someone suicides. It predicts propensity to suicide. That impulsivity and emotion dysregulation are essentially, according to this model, necessary but non-sufficient for maximizing vulnerability. And that's, I don't mean that literally, but what that means is that neither impulsivity nor emotion dysregulation in and of themselves are enough to push someone up to the precipice, if you will, of self-injury and suicidal behaviors. That both of them have to occur together, and that's the definition of a statistical interaction. And so you're absolutely right. There are all sorts of psychiatric disorders, if you will, that are characterized by impulsivity. There are all sorts of psychiatric disorders that are characterized by emotion dysregulation. Not all of those disorders have high suicide rates or rates of non-suicidal self-injury. It's the confluence of the two that matters, according to our perspective.
All right, another highly upvoted question. This one from Luke Clark, I know you spoke with earlier. Awesome talk. Do you think impulsivity is sufficiently stable over the lifespan? Wait, oops, did I read it wrong? Do you think impulsivity is sufficiently stable over the lifespan such that this is still key in older white males? I've heard colleagues in Pittsburgh say that suicidal behaviors in seniors are most risky when they are highly premeditated, so not so impulsive.
So that's a good question. It brings up a couple of important issues. So one is impulsivity stable across development? And the answer to that is unequivocally yes. And so impulsive preschoolers are impulsive 20-year-olds, are impulsive 50-year-olds, are impulsive 70-year-olds. And so individual differences are preserved across development. But there are large developmental differences so that mean levels in the population of impulsivity go down as people mature across adulthood. And so the answer is complicated, and my hunch is that impulsivity is less involved, as the question suggests, among older white men who suicide, and instead they're making a rational, premeditated choice. And this is anecdotal, but that was certainly the case with my grandfather. He didn't decide one day that he was going to check out from this unbearable situation. He thought about it over an extended period of time.
I didn't know this could happen, but apparently people can piggyback on questions. And so what I just noticed that Amori had a piggyback question on Luke's question, which was, alternatively, does impulsivity exist in older adults, but we have trouble measuring it because it doesn't manifest, as it does in kids, by jumping on furniture?
Yeah, it can be measured in, there's some fabulous paradigms like delayed discounting tasks that measure impulsivity and correlate pretty strongly with those behavioral measures. And you can certainly measure that in older adults. And self-report measures as well of things like exuberance, insurgency, and disinhibition hold up well to age, but certainly not jumping on the couch, at least not in my experience with hanging out with 70-year-olds.
They want to jump on the couch, they just can't.
That's right, yeah. If only we could still do that.
All right, highly upvoted question. You might have to speculate though. What role do you think father-daughter conflict plays in suicide and self-injury risk for girls? The research seems to almost exclusively focus on mother-daughter dyads.
Yeah, and I think everyone's onto this and acknowledges it. It's so hard to get fathers in disadvantaged families and dysfunctional families, for lack of a better word, to come into the lab and participate in this kind of work. I have a colleague, Sarah Shopey-Sullivan, who brings a lot of fathers into the lab. It's painstaking. She still doesn't get fathers who in the most severe families, if you will, or most coercive and conflicted families. And so what's going on with dads, I'm not sure. And it would be so speculative on my part. My guess is, knowing what I know from the externalizing literature, and knowing that many girls who develop borderline personality disorder later in adulthood come from the same families as boys who develop antisocial personality disorder, something that we've known for decades, that father involvement is an enormous issue. But that's extrapolated from a couple of degrees of separation.
Great. I'm in a good way struggling in my moderating role, because more comes in and then there's upvotes. But there's one that I was about to upvote, so I'll use privilege and bring up that question. So this question says the pattern that you're talking about and presenting seems to be driven in part by the impulsivity facet of ADHD. Would you expect to see similar or different patterns in the inattentive subtype of ADHD in girls? And my own question actually goes right to the heart of like the nature of impulsivity and how different people have different definitions, which is one reason why I'm too interested in this question.
The answer appears to be no, that this is not relevant, or put the other way, that the inattentive only subtype of ADHD does not portend vulnerability to non-suicidal self-injury and suicidal behavior. This is a tricky question, though. And it's tricky because according to, and we've written a bunch about this ourselves, according to some theories of ADHD, the reason that you essentially can't find kids with ADHD who are purely hyperactive and impulsive is because hyperactive impulsivity gives rise to inattention epiphenomenally. And what I mean by that is if someone's hyperactive and impulsive, they can't pay attention to anything. Those behaviors preclude paying attention. Whereas someone who's only inattentive, that's their primary presenting problem. There are different neural substrates of primarily inattentive ADHD, and it's much more parietal. Whereas hyperactive impulsive ADHD is much more striatal. And so I realize this is a circuitous, long-winded response to the question, but the answer is no, that inattentive ADHD, that parietal dysfunction does not appear to confer vulnerability to self-injury.
Great, thank you. How do the effects for young girls and older men vary by socioeconomic status?
Yeah. That's an open question, I think. That the two studies that I'm drawing data from are the Berkeley Girls with ADHD longitudinal study, which is a relatively privileged sample compared with many studies of child psychopathology. The Pittsburgh Youth Study is not. If anyone else is aware of associations between suicide and socioeconomic status in older white males, that would be great to hear. It would be great to hear from that person. I'm not aware of that association. So I can't answer that question, I guess is the simpler way to say it.
Got it. It's possible this next one will involve more speculation. Can you speak about the impact of social media on pre-adolescent girls' propensities to self-injure and attempt suicide?
Oh, absolutely. There are others who have studied this, and it's good work, that there is undeniably a social contagion aspect of non-suicidal self-injury, that one can't explain why non-suicidal self-injury was almost unheard of 30 years ago, whereas 20% of girls, as I said, at least dabble in it now without a social contagion aspect to their theory. Nothing has changed in terms of our cognitive architecture or emotional architecture in that period of time. Social contagion probably goes most of the way toward explaining higher and higher rates of non-suicidal self-injury. And of course, if the behavior is modeled for someone, then that vulnerability, if they had vulnerability, it can draw that vulnerability out. I liken this to substance use. One can have all the genetic vulnerability to alcoholism or addiction of another kind in the world, and that he or she will never know it if they don't expose themselves to that substance. And non-suicidal self-injury is the same way. One can be very vulnerable and never have problems. Well, they'll probably have other sorts of problems, but never have the problem of non-suicidal self-injury if someone doesn't show them and they don't hear about it in the media, on social media, etc. So, yeah, good question.
Yeah, I appreciate the answer. I've spent some time in the self-injury world too, and that seemed to be a point many people miss, is that you can't self-injure if you never get the idea.
Yeah, yeah.
All right, so we're starting to get towards the end. I'm going to see if we can get two more questions in. For the negative angry mothers that drive, okay, so the study on negative angry mothers driving daughters' behaviors, did the study account for the length of time of the self-harm or depression of the daughters? And what the reasons were for the behavior diagnosis?
No, and so we took all comers who either reported 3 or more self-harm episodes of moderate lethality or 5 or more lifetime. What we do know about motivations for self-harm and suicidal behaviors is all written by David. So he might be able to say more than I could about that. But we didn't map individual differences in motivations onto those affective dynamics, nor did we evaluate length of time of self-injury in those associations. So those are good questions that I think we'd have to answer with a larger sample than we had. So those sample sizes with about 25 per group, you've got rich behavioral data across a task to evaluate, but when you start looking at how individual differences correspond to those things, you lose all your power very quickly. So we need a much bigger sample, but it'd be interesting to see the results.
I think we can sneak in one, maybe two. If impulsivity is stable across the lifespan, what are some effective ways to regulate that to minimize the negative impact on quality of life or self-injury and suicidal behavior?
Oh, I love this question because no one ever asks it, at least in that way. And both in terms of our work on non-suicidal self-injury, and we've actually written more about externalizing development in males. Impulsivity is so highly heritable that it's going nowhere. So if you have clinical levels of hyperactivity and impulsivity, and let's just consider impulsivity for the moment because hyperactivity tends to wane across age, whereas impulsivity doesn't. That is a fabulous candidate for radical acceptance. That is a personality trait that's so embedded that that the best thing that we can do is accept that about ourselves and learn to live with it. However, that said, emotion regulation turns out to be key, right? If we can regulate our emotions, our impulsive emotions, and the same is true for trait anxiety as well. That's not going anywhere, and the best we learn to do is accept that about ourselves and learn to regulate our emotions around it. And so it's the situation is such that, as I described it, it's when impulsivity is combined with poor ability to modulate our affective reactions that the worst outcomes are seen. And Ben Hankin and others have argued the same thing for internalizing. And so I always like to provide examples. All of us have a colleague, I'm sure this is true at UBC as well as at Ohio State, who's very impulsive, yet is highly successful. And I classify that as regulated impulsivity. Whereas others who are very impulsive and poorly regulated couldn't possibly function in academia. And so that's my view on that.
All right, there's one more question that's a nice substantive one that we're out of time technically, but maybe 1 or 2 minutes is okay. You referred to hyperactivity, impulsivity in your talk and in your previous answer. Have you looked at other types of impulsivity, not inclusive of attention or inattention, perhaps even reward-related, delay or probability discounting impulsivity? Would it be safe to make this sort of interpretation given the CNS functional vulnerability results you spoke of in your talk? I'm curious to see if other types also involve the striatum. It's a mouthful.
That's a mouthful. It is, but it makes good sense. And so here you're going to get a bias from me, and I'll label it as such. And that is, I don't place a lot of stock in measures that parse impulsivity into multiple components. That there's not necessarily a good correspondence between neural mechanisms of impulsivity and different facets of self-report measures. So what were the two? Reward-related impulsivity, and the other was delay discounting?
Oops, delay or probability discounting.
Yeah. I have to be convinced that those are really two different constructs, and I'm not. Maybe somebody could convince me of that. And I also, I know Sherry Johnson at Berkeley has written a lot about emotion-related impulsivity. And to me, I would rather think about impulsivity and emotion regulation as two different things, and not put them on the same axis, if you will.
All right. Well, we went over time a little bit, but I'm really appreciate not only the chance that we all got to hear you speak, but that we got a chance to address a lot of questions. I'm pleased how that worked out. So thank you, everyone, and thank you for that. And let's see, there's a message. Thanks.
Yeah, thank you.
Thank you for the wonderful talk and discussion. I'm sorry.
Thanks, everyone. This is weird if you haven't done it. So I appreciate everyone and their questions.
It is weird. Thank you very much. And yeah, next time maybe we can actually have you out here.
Would love that.
All right. Take care, everybody.